Hi. So this is our second video on tumors. Okay. So the last video we had discussed what tumor exists in which site. Okay. So one thing I have told this before also. In orthopedics is very vast. I mean, we took 3 years to just clear the PG exam. Okay, the residency. I mean, so for an entrance, you should never try to go into the depths of everything. So tumor, if you go into it, there is so much to know, and you will just keep going on. So always concentrate on the high yield topics. So I don't think I should be covering. It's not a good thing for me to cover everything about all the tumors. That is not going to be high yield for you, and that's going to stuff you with a lot of information, which may or may not help you. Okay, so I'll go over important things about important tumors. Okay, so we discussed what are all the how do you classify the tumors, what are the common tumors. Okay, in exam point of view, whenever there are choices, so these are all the choices which are commonly asked. Okay, this would be one of the choices, and so note 2 or 3 things about each of these tumors. Okay, first cysts, they are commonly asked. So there are 2 types of cysts. One is aneurysmal bone cyst, and the other is a simple bone cyst or a unicameral bone cyst. Uni means single, cameral means chamber, so there is a single chambered cyst. Okay, then next one commonly asked, the it's not a, so there are 2 kinds of tumors, right? One is completely benign, the other is completely malignant. So in between them there is a tumor which is called the giant cell tumor. So it's an aggressive, it's benign though, but it's aggressive. Okay, so that is also commonly asked. So you should know everything about giant cell tumor. And then common tumors are obviously going to be your malignant tumors. So the primary bone malignancy is multiple myeloma. Okay, but the most common malignancy in bone is metastasis. Okay, so never forget this. The most common primary bone malignancy in adolescent or in children is osteosarcoma, and the second most common malignancy, primary malignancy of the bone in children, especially when the question is asked mentioning that the children are less than 5 years of age or 5 to 10 years of age. I take it back, not less than 5 years of age, primarily between 5 and 10 years of age. So in younger kids, if they are asking about a tumor, then Ewing sarcoma, you should keep that in mind, especially if a tumor arises from the diaphysis. Okay, so these are the commonly asked tumors. And apart from this, whenever there is a question on tumors, always keep in mind that osteomyelitis or infection can be a differential, especially in PGA when you have multiple questions. If you have a lytic lesion somewhere, and you should always keep in mind that infection can also be a differential. Okay, so we'll start with the important X-ray findings in these common tumors. Okay, so giant cell tumor. Giant cell tumor we discussed was that day epiphyseal, more than 20 to 40 years of age. Okay, skeletally mature patient with an eccentric, expansile, lytic lesion. Okay, it's eccentric, expansile, and lytic. What is eccentric? So this is the bone. Okay, if it arises from the center, it's not eccentric; it is centric. But if it arises from the out from the side, and it, that is eccentric. So this is not centric. This is eccentric. And usually the giant cell tumors are like this. So they are going to be expansile lesions. So they are going to expand the bone, and this is going to be a lytic region. So this is how a giant cell tumor typically presents. It extends all the way to the subchondral, that is the cartilage. Okay, it's just below the cartilage, and that's why these lesions can present with subchondral fractures. They can present with severe pain in the joint. Okay, eccentric, abutted by the subchondral bone or plate, soap bubble appearance. Soap bubble appearance because these are multiloculated lesions. So there are always going to be multiple chambers within the giant cell tumors, and therefore it looks like a soap bubble. Okay, so this is with regard to giant cell tumor. You should know these points. Then the 2 cysts. Okay, so there is a simple bone cyst, there is a aneurysmal bone cyst. So the simple bone, they both are important DDs to each other. So the simple bone cyst, it's called simple bone cyst because it is very simple in terms, it is well defined, it is usually not expansile, but it can be expansile. When does simple bone cyst become expansile? It is when these cysts, they can cause pathological fracture. So every time the patient undergoes a pathological fracture, there is going to be healing, and the bone is going to be, new bone is going to be formed, one layer of the other. These patients can have multiple fractures, so they can actually result in something like an expansile lesion. But for exam purpose, you should remember that simple bone cysts are simple, so there's usually no bony expansion. It is very well defined, and it can be trabeculated, but usually, as I said, it's uniloculated. There's a single chamber, unicameral. Okay, and most of the times this is not the right place that I should have drawn it. It is most of the times it is in the metastasis. So almost always it is in the metastasis. Metaphysis. Almost always the simple bone cyst arises in the metaphysis and not in the epiphysis or the diaphysis. So this is all the important points about simple bone cyst. So simple bone cyst, single chambered, not much bony expansion, well defined lesion, and it arises from the metaphysis, and the patient can present with pathological fracture. Okay, the third important differential, aneurysmal bone cysts. Aneurysmal bone cysts are again, they are going to grow. Aneurysm is when it grows, right? So aneurysmal bone cysts are a little more aggressive kind of cysts. So they can be multiloculated, they can be eccentric, they can be expansile. Okay, and they are also metaphyseal. So unicameral bone cysts and aneurysmal bone cysts are important differentials for each other. Usually when it is a little more aggressive with multiloculations and eccentric, expansile, it is an aneurysmal bone cyst. Okay, and then the important differentials you should know about the malignancies. So most common primary malignancy of the bone, multiple myeloma. So these present with punched out defects. So what are punched out defects? So there's just lysis of the bone because it's a marrow tumor, right? So the marrow keeps on growing. There is no bony tissue that is formed, no calcification, no ossification. So it is like there's a bone here, there's just some holes there, punched out lesions. And there is commonly involving the flat bones, the skull, the pelvis, the vertebrae. It can also involve the proximal femur. So these are common lesions. And in the long bones, it typically involves the metaphysis. Any malignancy, it involves a metaphysis because that's the most vascular portion of any long bone. Okay. Then the next most common primary malignancy, especially the primary malignancy in children and adolescents, is osteosarcoma. So osteosarcoma is a bony tumor. It is not like myeloma. It is not a marrow tumor. It's a bony tumor. So the bone. So whenever there is a tumor, there are two things which happen. We always say, whenever you describe any tumor on the X-ray or anything, you should think of two things: what the tumor does to the bone and what the bone does to the tumor. Okay. So any tumor, it destroys the bone. So that is one thing. And there is always so this is the tumor. It's a very aggressive tumor. It is destroying the bone. So what is a normal bone? If this is a normal bone, what does it try to do? It tries to put some more bone there. Okay, and it tries to contain. It does its best to contain the tumor. Okay, so that is called the periosteal reaction. They always ask you what kind of periosteal reaction. You should understand what it means. So periosteal reaction. Periosteum is the place where it can form the bone. The bone forming layer of the periosteum is called the cambium layer that produces bone. So whenever there is a stress to the bone in the form of a malignant tumor, aggressive tumor, the body tries to wall off the tumor by putting forth its main soldier, which is the periosteum. And the periosteum it thinks that it can produce bone and can contain the lesion. That's what a periosteal reaction is. So in all these malignant tumors, which especially arise from the bony cells, like the osteoblasts, like in osteosarcoma, you have specific periosteal reactions. So right now, until now, we were talking about simple bone cyst, aneurysmal bone cyst, giant cell tumor, multiple myeloma. In all these four lesions, these are commonly asked but none of them there is like a typical periosteal reaction. Okay, we as orthopedic residents, there are specific periosteal reaction even in these tumors, but you don't need to know. Okay, so just remember that these tumors didn't have any periosteal reaction, but now what we are going to talk about, they have characteristic periosteal reaction. Okay, so osteosarcoma, these questions are asked, so always know about them. It's called a sunburst appearance, osteosarcoma. Lesion in metaphysis, it can be osteosarcoma. Usually a combination of osteolytic and osteoblastic lesion, it can be osteosarcoma. Codman's triangle, osteosarcoma. And then when they say poorly defined endosteal margin or endosteal surface, think of osteosarcoma. 5 points, all these 5 they have asked as questions in the past. Okay, so let me talk about these two periosteal reactions a little bit for you to know what they are, so that you don't need to by heart. So whenever there is a malignant tumor, okay, as I said, there is a tumor, it's a very aggressive tumor, right? So there is a bone here, there is a tumor here, and it keeps on growing. So the tumor does not grow everywhere. So there must be a point where the tumor grows. So like this, the tumor grows. There is some new bone just between that. So it produces periosteum. It tries to wall off on both sides. There is a little bit of lesion, and again it walls off. So everywhere you will find at one point there is a walling off, and tumor in between. Okay, at some point it looks like this. Okay, during the growth of the tumor, and that is the sunburst reaction. Similarly, when there is a tumor that is growing up like this, okay, it's like this, and then on both sides there is a periosteum. It tries to wall off by putting in more bone. So this is all lytic. So it actually looks like this. When you see on the X-ray, this won't be seen because this is all tumor tissue. But the normal bone, it forms 2 triangles on either side. That is a Codman's triangle. But in Ewing sarcoma, it is different. So osteosarcoma was metaphyseal, like any other aggressive tumor. But Ewing sarcoma is diaphyseal. Ewing sarcoma, it's in younger children. Osteosarcoma is usually between 10 to 15 or 10 to 20 years of age, whereas Ewing sarcoma is 5 to 10 years of age, younger children. Ewing sarcoma comes under PNET. That is the round cell tumors or the blue cell tumors. Okay, it comes. So Ewing's, as I said, is diaphyseal. It is also fast growing. So sunburst appearance, Codman's triangle also can be seen in Ewing's. Okay, but the most important thing is with Ewing's, it's very typical kind of growth. Like in osteosarcoma, it is very aggressive, so it just kind of grows and grows and grows. Whereas Ewing sarcoma, it grows in cycles. So there is a period of fast growth, and then there is a small pause, fast growth, small pause, fast growth, small pause. So every time the tumor grows, okay, and then it slows there. So that time the body thinks, yeah, okay, something is contained, and it tries to form a bone. Okay, and then again, but now the tumor again has woken up and it starts growing again, and then there is a small pause and the bone forms another layer. Okay, then again another tumor growth, bone forms another layer. So this is a lamellated periosteal reaction, or if you see in a cross section, so it will be like this. It's called an onion skinning appearance, onion peel appearance, and cycles. Okay, so that is very typical in Ewing sarcoma.